Thank you for joining us today for the 5th Annual Policy Summit presented by the American Association of Kidney Patients. This year's summit is titled Patient Voice, Patient Choice, New Determinants for Kidney Policy. My name is Ed Hickey. I'm president of AAKP and serve as the chair of the Veterans Health Initiative. Professionally, I'm a veteran United States Marine Corps infantry officer. My public service career includes posts on Capitol Hill as an administrative assistant to a United States congressman and a special assistant at the United States Department of Congress under George H.W. Bush. Following the terror attacks of September 11th, I also served as a senior advisor for Homeland Security for the Director of the United States Civil Service under President George W. Bush. Currently, I'm a practicing attorney in Los Angeles. I'm active in the armed forces legal community, working locally with the Veterans Legal Service Project of the LA County Bar Association to support the legal needs of active military personnel, reservists, and veterans. And at a personal level, I'm a fellow kidney patient. I'm also an experienced caregiver and patient advocate because of the history of kidney disease within my family. I'm pleased to introduce our session titled Critical Barriers to Care Transformation: How Payment Policies Impact Kidney Patient Consumers and Innovation Leaders. AAKP has, for over 50 years, been a champion for patient choice and innovation in kidney medicine, including therapeutics, diagnostics, and devices. That is why AAKP fights for solutions that help diagnose disease earlier, slow disease progression, and helps stop kidney failure. We are strong advocates for preemptive transplantation, greater access to kidney transplants for all patients in need, and home dialysis. AAKP defines high-quality kidney care as timely patient access to therapies that keep patients healthy and fully capable of pursuing their aspirations, such as maintaining a career in meaningful part-time or full-time work, starting a family, owning a home, and retiring securely. After decades of stalemate and little innovation, the kidney community is witnessing a golden era in kidney drug and device development. That is why, in part, AAKP declared the next 10 years is a decade of the kidney. In the past several years, the U.S. Food and Drug Administration has approved several new and safe treatments that help patients better manage kidney diseases and related conditions. AAKP anticipates more approvals in the coming years. These approvals require tremendous research, investment, patient participation in clinical trials, and advocacy. And to be clear, each FDA approval is a significant victory for kidney patients in need and the companies and researchers who have committed themselves to transforming status quo kidney care. Yet these victories are incomplete if patients cannot access the drugs and devices once the FDA has found them to be safe and approved for patient use. Patients, medical professionals in the industry are becoming increasingly frustrated by the cumbersome barriers to patient consumer access to the innovations patients have fought for decades. Some payers, including insurance companies, and at times the Centers for Medicare and Medicaid Services, or CMS, either intentionally or through a lack of understanding of the patient burden of kidney disease, erect barriers to access these FDA-approved treatments. In some cases, some payers do not support these innovations at all. AAKP believes access must be addressed now because access to future innovations will be negatively impacted if we are not successful in these initial fights. Fighting for patient access to new innovations takes courage, political sophistication, and the fortitude to win. This is why AAKP launched its Patient Voice, Patient Choice Initiative in 2022. Through this interactive platform, patients and care partners can quickly identify barriers impacting care, choice, and treatment. Through AAKP, patient consumers can engage elected leaders, government agencies, and payers to raise their voice when timely access to safe, FDA-approved treatments and devices are hindered by nonsensical barriers. Simply put, AAKP is 100% committed to making certain patients receive the right treatment at the right time based on the guidance of the doctors they choose to give them care. Our first speaker is Chris Leibundguth, Director of Federal Government Affairs and Alliance Development for Baxter Healthcare Corporation. AAKP has collaborated closely with Baxter over the past decade on a wide range of issues related to home dialysis and patient access to new technologies that reduce the burdens associated with in-center dialysis care. I'm pleased to say I met Chris during his first week on the job at Baxter, and that his commitment to the principle of patient care choice is nearly unparalleled in the kidney community. Chris, I turn it over to you.
Hello, my name is Chris Leibundguth. I'm the Director of Government Policy and Reimbursement for Baxter. I want to thank AAKP for inviting me to speak at the Policy Summit. Today I'll be talking about shared decision making, what it is, how it impacts patients who are living with chronic kidney disease, and then some public policy considerations related to shared decision making. So what is shared decision making? Shared decision making is an educational process whereby patient preferences and values are included in decisions about care plans and treatments. The way that those patient preferences are gotten to is by educating the patient about all of the options that are available to them. And then once the patient is fully educated, then their preferences can be utilized effectively in making those decisions. Now, shared decision making is used in lots of therapeutic areas across healthcare and has been around for quite a while. So then that begs the question, what does shared decision making mean for patients living with kidney disease? And where that really comes into play is the decisions that are made around when or if a patient's kidneys fail, right? That's really sort of what shared decision making comes down to for the chronic kidney disease population. And what that ultimately then means is its decisions around modality choice. There are other things that play into shared decision making, things like education on transplantation and vascular access. But really what this really means is when a patient's kidneys fail, what are those patients' preferences when it comes to whether they dialyze at home or dialyze in a center? Or what are those patients' preferences when it comes to whether they dialyze using hemodialysis or peritoneal dialysis? That's really what shared decision making means for patients living with chronic kidney disease. And then finally, what does shared decision making mean when it comes to public policy decisions? This really comes down to reimbursement. Policymakers oftentimes want to incentivize shared decision making. It's a method for them to really ensure that patient preferences are included in those decisions. And the mechanisms and the levers that they have to incentivize that comes down to things like payment and reimbursement. That's really how they enter into this equation. So in the United States, we actually have a piece of public policy that encapsulates shared decision making. In 2010, a Medicare benefit was created called the Kidney Disease Education Benefit. And what it does is it reimburses providers for spending time educating patients about modality choice, transplantation, and vascular access, among other topics. Now, what you see here on the slide are two columns. One lists benefits, the other one drawbacks. And I think it's probably wise to think of the benefits as sort of the promise of what the KDE benefit could or should be delivering. On the other side with drawbacks, that's really sort of a lot of the learnings about what the KDE benefit has done over these last 10 years. And so in terms of benefits, what the KDE benefit really does is it promises to do is to facilitate conversations between clinicians, nurses, and CKD patients. That's often, when done correctly, what that means is you have a patient that has informed information and can actively participate in those decisions. And also it becomes a platform for utilizing the latest educational techniques in terms of ensuring those patients can retain action-oriented information. Now, unfortunately, the KDE benefit is very underutilized. And one of the key features of it is that the reimbursement is often judged to be somewhat low. So not sort of the type of reimbursement that's really going to catch the eye of providers. In addition to that, there's no standardization about what KDE actually is. And that can be a problem because it can create a fractured landscape of different types of educational materials, some of which could be very effective, but others that may not have any effectiveness at all, but they're being utilized in order to use the KDE benefit. And finally, there was a big question around who should be educated and then who's doing the educating. And so some other features is that CKD benefit excludes CKD stage 3 and 5. So not all CKD patients get educated through the CKD benefit, only certain ones do. And then in addition to that, not the entire sort of provider landscape can reimburse for it, only clinicians and nurses, but not facilities. There is one caveat, and that is that in the ETC model, CMS did propose at one point to include facilities in the CKD benefit, but recently that was withdrawn. So last year, Baxter conducted a survey of educators, nephrologists, and large and mid-sized dialysis facilities, trying to get more information and insight into how the KDE benefit is used. And here for the next 2 slides, I've drawn a couple of the more interesting takeaways from that survey. And the one that you're looking at here, this really sort of covers the most common reasons for this underutilized KDE benefit. And you see a laundry list of rationales in terms of how these different types of providers believe why it's being underutilized. But the one that really sticks out and is at the top of the list is that nephrologists are oftentimes sending patients for education to dialysis centers or other locations because they are focusing their time on other parts of patient care and education. And so that creates sort of a weird dichotomy where the KDE benefit is utilized only by clinicians and nurses, but then clinicians and nurses are oftentimes sending those patients to facilities to get the education, and thereby you're sort of undercutting the rationale for the KDE benefit. The other interesting takeaway is what types of information is being utilized here. So you see here 2 columns, one that shows commonly used KDE materials, the other one commonly used KDE sources. And what you really see here is a fragmented array of different types of educational materials being used. And so most common are pamphlets and brochures and booklets. And then the rest of it is mainly websites with a few people getting handouts and even a smaller group taking courses or classes that are going to educate them on their treatment options. And then on top of that, the most common sources are online sources. What this ultimately entails is maybe providers going in and looking for materials online, doing web searches to try to pull information up that then they turn around and use to educate patients. But what you don't see is a sort of standard platform of education that's being used to render this KDE benefit. So I want to conclude today by reviewing some items that I think would fit into a framework for policymakers to understand both how to utilize shared decision making, but specifically how to utilize it through the kidney disease education benefit. So the framework consists of these 4 elements. First, ensure that there's adequate value for the service. This means potentially better reimbursement for the KDE benefit, but I think it goes beyond that. Lots of organizations in the CKD space have spent a lot of time and effort thinking through how to deliver education that really matters to patients. That educational pursuit has a lot of value. It has value for the patients individually. The better informed they are, the better that education is at ensuring that they retain the information so they can really be active in their care decisions. Is really important for them individually. But it's actually really important for the system writ large. An informed patient that makes the best decision for themselves is most likely going to be a less costly patient to the system. And so this is the type of thing that we really want both governments, but also organizations to think through. What's the value of their educational tools, and make sure that value is very, very much present in what they're doing in terms of delivering it to patients. Secondly, the information must have standards. And we saw it in a previous slide that there's sort of this fractured environment of information out there for patients to be educated. Organizations like AAKP are putting a lot of time and effort in thinking through what are the best ways to educate patients. And we really want policymakers to understand that, to maybe start to make decisions about what is and what is not education when it comes to reimbursing for the KD benefit. Doing that would ensure that the information out there available to patients really is the best possible information that is validated and tested and is proven to be effective versus information that's simply you find on the internet through web searches and is handed off to patients and hope that they read it and educate themselves. We really want education techniques and tools to have that sort of standard set of values so they really can deliver something positive to patients. And the last two elements really have to do, again, with who gets educated and who is doing the educating. And then with this one, I think there's a guiding takeaway, and that is we really want to ensure that for both of those, that however the policymakers divide it up, that it ensures maximum exposure to the information. And so if you're talking about patients, right now, just CKD4 patients can receive this CKD benefit, or the providers can receive it for educating them. It's worthwhile thinking about whether that should be expanded to CKD5, and maybe worthwhile thinking about how many other CKD patients should be exposed to this type of information under the right circumstances. And then beyond that, there's a big question about who should be doing the educating. And in here right now, as we said before, this is clinicians and nurses, but there is a bit of a disconnect there. You have clinicians and nurses doing some educating, but for a large part, that education is being delivered by facilities and by other educators. We want to make sure that those educators are also inclusive of this, particularly if they're the ones who are doing that type of work. The people who are out there doing the best education should be the one who are being incentivized to do more of it. So that's the framework that we want to make sure that policymakers understand. This is a conversation we want to continue to have with AAKP and other organizations, and we think that we can arrive at this type of framework in terms of our advocacy going forward. So with that, I want to thank you so much for your time today, and happy to take any questions.
Thank you, Chris. That was an excellent presentation. I'd like to now welcome Sharon Griff, Managing Director of the Griff Group. Sharon is a former board of director of the AAKP and a longtime patient advocate. She was a member of our board of directors when AAKP formally adopted our new national strategy, putting the organization on the path to an unprecedented level of growth over the past 8 years. Sharon, I turn it over to you.
Well, I really want to thank AAKP for having me come and speak today. My name is Sharon Griff, and I'm a registered dietitian by training, and I'm a market access consultant. And my role is to really make sure that patients have access to new products in development. I've been working in the field of kidney disease for over 25 years. Today's topic regarding how CMS policies impact innovation in the management and treatment of patients with kidney disease on dialysis is quite timely. There has been limited development in this area, and as a community, we need to work together to ensure that over the next 1 to 5 to 10 years, we're able to change this. So let's start at the beginning. The ESRD Prospective Payment System, also known as the ESRD PPS, went into effect on January 1st, 2011, about 11 years ago. At that time, CMS moved the payment for dialysis and related dialysis services, including drugs and labs, from a fee-for-service model where items were separately payable to a bundled payment model. All of the services would now be reimbursed under an all-inclusive bundled rate. There are many factors that go into this bundled rate, and it changes every year. At the time the ESRD PPS went into effect, CMS did not include any allowance or adjustments for new drugs coming to the market. As you can see from this slide, there have been 3 drug approvals and 4 drug launches since the ESRD PPS went into effect. Mircera, an ESA, was originally approved in 2007 and launched at the end of 2014. Parsabiv, an IV calcimimetic, was approved in 2017 and launched in early 2018. Retacrit, a biosimilar to Epogen, was approved and launched in 2018, and Korsuva, an antipruritic drug, was approved in 2021 and launched in 2022. There have been other drugs launched, however. These drugs are covered under the Part D benefit, not the ESRD PPS. I am sure many of you are aware that during this same 11-year period, the FDA has approved hundreds of drugs. However, only 4 came to market to treat conditions associated with dialysis. In this same time period, dozens of life-changing medications have been approved in oncology, neurology, and rheumatology, just to name a few. In addition, breakthrough technological advances have been introduced in many other markets. Let's dig a little deeper. As I said earlier, in the original ESRD PPS, CMS did not have any payment for new drugs coming to market. When Mircera was launched, it was covered in the bundled ESRD PPS rate from day one. In 2016, CMS introduced the Transitional Drug Add-on Payment Adjustment, also known as TDAPA. Originally, TDAPA was developed as a payment adjustment for injectable drugs that were not included in an existing functional category. Let me explain what a functional category is. The functional category is a system designed by CMS. It groups products into categories based on end action. For example, there is an anemia management category, which includes drugs used to stimulate red blood cell production and/or treat or prevent anemia. Currently, this category includes ESAs and iron. Overall, there are 11 functional categories developed by CMS. Parsabiv was approved in February of 2017 and launched January of 2018. Parsabiv and its oral counterpart, Sensipar, that had been on the market for 15 years, were the first 2 drugs to be covered under a TDAPA. At the time of its approval, Retacrit did not meet the criteria for a TDAPA and was covered under the bundled payment rate at launch. In 2019, CMS expanded the eligibility criteria for TDAPA to include new drugs that were included in functional categories, and in 2020, CMS refined the eligibility criteria further. In August of 2021, Korsuva was approved and was granted a TDAPA effective April 1st, 2022. Let's take a closer look at how TDAPA works. CMS uses the functional category to determine how drugs will be paid. If a new ESRD drug, and I'm looking at the first column, is in an existing functional category and meets the eligibility requirements, they will be granted a TDAPA. The TDAPA payment rate is ASP plus 0. The product will get this payment adjustment for 2 years. At the end of 2 years, the drug will be covered under the bundled rate and no additional adjustment will be made. If a new ESRD drug is not in an existing functional category, they will be granted a TDAPA. The TDAPA payment rate is still ASP plus 0. The product will get this payment adjustment for at least 2 years. CMS will collect utilization and cost information during this time period. And at the end of the TDAPA period, CMS will calculate a base rate adjustment and change the bundled rate to include this new product. But what does this mean for access to drugs? Well, pretty much any new drug that's going to come into market will fit into one of the current functional categories designed by CMS. There can be new drugs with new MOAs that are superior to current treatments, but the way the rule is written, this new drug would not receive a payment adjustment when the TDAPA period ends. This lack of long-term reimbursement significantly reduces patient access to new therapies. And finally, the payment rate itself. CMS reduced the payment rate for TDAPA drugs in 2020 from ASP plus 6%, which is the rate for separately billable drugs under other payment systems, to ASP plus 0. With sequestration, reimbursement is below ASP. It appears CMS has heard the challenges that patients and providers are facing in regards to long-term reimbursement and has recently requested feedback on a new payment proposal post-TDAPA. We are hoping to learn more next year. So why does the ESRD PPS and the TDAPA policy hinder innovation in kidney disease? Well, let's think about this. It typically takes at least 10 years to develop a new drug, and the payment mechanisms are constantly changing. There are so many unknowns. Will TDAPA eligibility change over time? Will the payment rate change? Will it be reduced again? Will there be long-term payment mechanism post-TDAPA? How will that rate be calculated? How long will the rate be available? Which drugs would qualify? And so many, many more. If you are a manufacturer determining where to invest your resources for a new product that will not be coming to market for 5 to 10 years, it is very difficult to justify investing in treatments for conditions associated with dialysis because the payment mechanism available when you start may not be available at launch. For example, Triferic Avnu, a treatment for iron deficiency anemia for patients on hemodialysis, was approved in March of 2020. Initially, the manufacturer believed that it would receive a TDAPA after the eligibility update for calendar year 2019. However, 1 year later, CMS changed the requirements and this product was no longer eligible for a TDAPA and launched directly into the bundle with very little traction. For providers, the current policies make it difficult to offer new drugs when there is no long-term reimbursement or no reimbursement at all. CMS does not require Medicare Advantage plans to pay a TDAPA for these new drugs. Unfortunately, this has resulted in very spotty reimbursement from Medicare Advantage plans for TDAPA drugs. This is a significant issue as more and more dialysis patients are choosing Medicare Advantage every year. No other provider type would be expected to provide treatment without payment. Unfortunately, in the end, it is the patient that loses. The patient may not have access to new drugs or may lose access to drugs they were already on. And finally, the patients suffer because few manufacturers are willing and able to invest in innovative products to treat patients on dialysis because that funding goes elsewhere. Just to give a quick example as to how the ESRD PPS compares to other CMS payment systems, as well as the impact the changes in TDAPA have had. You'll remember from earlier in the presentation, I mentioned Redicrit. Redicrit launched in 2018 under the former TDAPA guidance, so it did not receive a TDAPA. Under the new eligibility requirements, because Redicrit is a biosimilar, it would be eligible for TDAPA now. In addition, Redicrit is used to treat patients outside of dialysis as well, in oncology and in earlier stages of CKD. When used in these other sites of care, Redicrit is paid separately at ASP plus 6% of the reference product or ASP plus 8% of the reference product, with the latter rate being a result of a recent CMS policy change for biosimilars. As a reminder, when used for dialysis, it is included in the bundled payment rate. So where does this leave us? I think we would all agree that we would like to drive development of innovative products for kidney disease, including for patients on dialysis. And very importantly, we want to ensure all patients have timely and long-term access to the necessary treatments. And I'd like to make a comment regarding timely access. With the way TDAPA works, drugs are unable to launch at approval with a TDAPA payment. Therefore, in both instances where TDAPA was granted, drug launches were significantly delayed post-approval. In other disease areas, drugs will have reimbursement at approval and can launch right away. So how do we get to a place where policies support innovation, and is TDAPA really the answer? Well, unfortunately, I think I've demonstrated that TDAPA may not be the answer to support innovation. The kidney community and CMS need to work together to develop a holistic policy. The current process with adding a new Band-Aid every year or two is not working and is not sustainable. The policy must be comprehensive and consider today and the future. One of the reasons we are in this situation is that the current policy updates are reactive instead of proactive. Patients, providers, and manufacturers need to have confidence and clarity in these policies. Finally, issues and questions need to be addressed in a timely manner. The current CMS system of annual rulemaking ends up leaving a lot of unanswered questions and issues for months or even a full year. This uncertainty adds to the already tenuous position patients and providers face daily. Overall, I think the good news is that there is a lot of momentum for change. The kidney community is very active, dedicated, and experienced, and will be able to collaborate with CMS to develop new, comprehensive policies to address these issues. So I'd like to thank you for your time today, and once again, I would like to thank AAKP for having me speak today on this very important and timely topic. And I hope you have a great rest of the day. Thank you.
Thank you, Sharon. Excellent presentation on a very important patient access issue. Our next speaker is Dr. Neil Warnock, Senior Director of Medical Market Access Data Generation and Observational Studies at Bayer. Dr. Warnock is a strong patient advocate with a particular interest in helping patients gain access to new therapies that delay disease progression and help stop kidney failure. He has worked close with AAKP staff to provide important insights on new, safe therapies entering the market and important related patient education efforts. Dr. Warnock, the floor is yours.
Thank you for having me today. I would like to introduce myself. My name's Dr. Neil Warnock. Today I'm going to be talking about who makes decisions regarding your treatment. So my presentation will focus on some of the potential barriers that may be in place restricting a patient or your ability for new and innovative therapies. Today I'm going to focus on patients with chronic kidney disease, often referred to as CKD or abbreviated as CKD, associated with their type 2 diabetes, or also known as T2D. So what are we going to cover today? I'm going to provide an overview of chronic kidney disease. Have you been diagnosed or told you have chronic kidney disease? Another challenge or issue for many patients with CKD and their type 2 diabetes is that they have cardiovascular or heart disease. You may have heard terms such as you have hypertension or heart failure. The pumps, the heart and the kidney, are not working well in patients with chronic kidney disease. This disease impacts both of those pumps, the heart and the kidney. What are some of the care challenges? What are the challenges and why it's important to get treated now, especially because there are new therapies available? CKD is a population health problem in the US. Another way of thinking about it is that chronic kidney disease affects a large number of patients in the US. There's often low awareness by patients that they have chronic kidney disease, and this can make managing the disease harder for doctors. It's often a silent disease. So in the early stages of the beginning of the chronic kidney disease, as patients would typically move or progress from having type 2 diabetes to chronic kidney disease, they're not aware. They don't feel any different. They may not have any symptoms. That's why it's called a silent disease. And then what are some of the key topics to know about how your health plan or your health insurance may impact what drugs your doctor is able to use to treat you? There are steps you can take to help improve your care, and we want to talk about what those steps are. So know your status. So if we look at the picture of the US, there's over 35 million patients or people with type 2 diabetes. Of those, about 40% will develop chronic kidney disease. So that's a large number. The other challenge, as I mentioned, is that a lot of patients that have diabetes and chronic kidney disease aren't aware that they have the disease. They don't know that they have chronic kidney disease. On the bottom, you can see that in the green part of the slide, it's important to know what stage you're at. There's the number of people with diabetes will continue to grow. So we'll have almost twice as many people by 2060 as we do now that have diabetes. And again, we anticipate the same percentage of those patients will develop chronic kidney disease. So it's important to know what stage you're in, and if you're have early stage disease or later stage disease, or what's known as end stage, right at kidney failure, and right before you would typically go to dialysis. Some of the facts on this slide, I think, really reinforce the importance of knowing your stage of disease. Your doctor may give you a number and say you're stage 1 or 2. There's 5 different stages, as I mentioned, 5 being the most advanced. So it's really important. Some of the things to consider: every 24 hours, 340 people will begin dialysis. This is a life-changing process for patients to go through. In the United States, diabetes and high blood pressure will cause 3 out of 4, 75% of patients with kidney failure. Without treatment, without getting the chronic kidney disease treated, it can lead to end-stage kidney disease, which patients then will have to go on dialysis or wait for a kidney transplant. The other important thing to note on this slide is that half, or 50% of all patients with chronic kidney disease wind up dying from their cardiovascular disease. So these patients, which you may be one of, that have type 2 diabetes and chronic kidney disease, about half of those patients also have some form of cardiovascular disease. On the bottom, you can see here that what we're going to now start to have a conversation around is the control your health insurance may have on what you as a patient receive. And it isn't always what your doctor has initially prescribed. So we can see that 14 million Americans may have trouble getting their medication that was prescribed for their chronic illness, as chronic kidney disease being one of those. These barriers can happen when your doctor and your health plan don't agree about what treatment you should receive. So getting tested is important to see if you have chronic kidney disease. Maybe you don't know if you have chronic kidney disease and you're a diabetic. Once you've been diagnosed or told by your doctor that you have chronic kidney disease, it's important to get the treatment, especially now that there are new therapies available. These are some of the problems in getting to care, is just testing. There's new incentives for both the doctor, your doctor, and your health plan to make sure that you're getting tested, to make sure that you get the appropriate diagnosis, and to make sure now that you get access to some of the new treatments. There haven't been treatments until last year that are new for chronic kidney disease. And so it's really important to make sure that you're getting the best treatment, the treatment that your doctor thinks would work best for you. On the bottom, you can see that chronic kidney disease or end-stage kidney disease, again, that would be those patients that go to stage 5, that's the most advanced, will occur more likely in Black, Native American, and Hispanic patients. So the top of this slide helps us explain what patients with chronic kidney disease have experienced again, over that last 20-year period until 2021. What's typically happened is there was a large number of patients that didn't get diagnosed. And a part of this is there weren't any new therapies. So there were not as many resources that were focused on getting patients diagnosed. Then the recognition of the stage or where you were at or where the patient's kidney damage was. Patients were getting diagnosed later in the process. So as you can see on the top there, stages 3 and 4, which is more advanced. And on the bottom, you can see that primary care physicians were trying to manage the bulk of this. The referral wasn't going to a nephrologist until it was right about the time the patient needed to go on dialysis. So on the bottom, what we can see is the referral to the nephrologist or the kidney doctor now can occur earlier if needed. But on the bottom, we're seeing that with a focus on testing earlier and having less patients be undiagnosed, that's represented in that dark blue color. The lighter blue color will have more patients diagnosed earlier. And now there's more therapies, more drugs, more options your doctor can provide for you. So with that, the goal is to get more patients that follow the pathway of the green, where they can delay their chronic kidney disease progression. So it's important that we focus on getting the best therapy for the patient. So in this slide, we're looking at 4 different guidelines that focus on the best treatment options for patients with chronic kidney disease. 4 different guidelines have been updated just this year in 2022. And because of these new treatments being available, this is based on a lot of new information for the guideline committees to review. All of the guidelines focus on the importance of your doctor choosing the best drug or drugs for you, the patient. All of the guidelines focus on improving patient outcomes or the results by using the drug with the best results from when they were tested. So they go through a testing and approval process before your doctor can write a prescription for you. It's rare to have this many guideline updates within a single year. It's the result of some very good data being available supporting new therapies. The guideline updates show the importance of your doctor having that ability to use the most innovative and best available drug to treat your chronic kidney disease. Part of the process now is that the insurance company or the insurance plan will use. And this is part of the challenge for your doctor, is what's known as a prior authorization. This is part of that. It connects back to the title of my presentation about who's making treatment decisions. So what is a prior authorization, or some of the steps a doctor must follow, regardless of the drug that they've chosen for the patient or for you? Your doctor has to follow this process based on whichever health insurance company that they're working with. So based on the insurance that you have, the doctor writes a prescription, and then they have to follow that prior authorization that may be in place for the chronic kidney disease medication. The prior auth process, as you can see here, is complex. They're written with clinical or medical input, and there's a business input or cost based on the cost of the health insurance when these are developed. So the bottom line here is that there's financial reasons why a drug or the ability of your doctor to write a prescription for a drug may require a prior authorization. So if we look at the slide, you can see starting on the left that the physician has ordered, in this case, we'll focus on a drug. Then it goes to someone on his or her staff that starts this prior authorization paperwork. There's forms to fill out. The staff can then check the requirements. Again, this is a complex process. The staff supporting the doctor then may have to call the health plan. They can be put on hold. The staff would then retrieve the forms based on what they're told to process the prior auth. Sometimes they're available online, sometimes they have to go to a different source to get those. Often those forms then get faxed back to the health plan. And then towards the end there, you can see where the PA becomes processed. This could occur as quickly as a day. It could be a month. Sometimes it's longer than that. And then based on the decision from the time when the doctor has decided that this drug is the best for you, their patient, to going through the PA process, one of two things occur. That prior authorization is either approved, which you can see by the green check mark, or that prior auth is rejected. So once they're rejected, the doctor and their staff have the option of appealing that rejection. In some instances, the patient then can receive the drug that the doctor ordered. But in those instances, when it's rejected, then that appeal process starts to initiate. And this can be complex. It may require the doctor to call or write or send an additional form to the insurance company. That appeal can sometimes take 2 to 3 steps or more before it eventually could either then be approved or rejected. The problem is that this could be days to weeks to months. And then based on how busy the doctor is that's written this prescription, there may be an alternative therapy or a second choice that the doctor could use. But again, due to the amount of time, to the cost, to the overall expense, the doctor and the patient don't always come together necessarily on what that second choice could be. There are times where patients then wind up not getting any therapy. And this is really unfortunate, especially now for those patients with chronic kidney disease, because there are new drugs available. To try and simplify the process, I'm going to walk through this example. So on the left, you can see there's 2 different types of treatment, 2 different choices that the doctor has to treat the patient. And they choose product A. Then as we move to the center, this is where that PA or prior authorization process starts to occur. The health plan requires the doctor to use product B instead of their choice, which was product A. So this is a barrier called a step edit, which requires that the doctor use product B first. Another barrier, as we've been talking about, a prior authorization may require the doctor to send a form or write a note or call the health plan or health insurance company as to why their choice of product A was made before the health plan will consider covering it or allowing it. The problem then are that all of these barriers will cause a delay in the patient getting access to the best treatment. So the medication that your doctor has decided is best for you is the right choice. There could be a long delay. And as I mentioned on the last slide, you may not get to an alternative or a second choice. Product A or product B, neither option may wind up being used for the patient. So this is a simplified general example. Every situation could be different. So it's important that you are your own best advocate. You need to consider action you can take now and really work towards supporting yourself to get the best care. So if you haven't been tested, get tested, as you can see on the left here. If you have diabetes and you're not sure if you have chronic kidney disease, or if you have chronic kidney disease, you've been told that by your doctor, make sure you get tested every year. It's important. In the middle, in the blue, have a conversation. Ask your doctor about treatment options. Most patients with chronic kidney disease take a lot of different medications, and there are options. There's medications available that can help delay heart and kidney disease and delay how fast or how quickly they progress. And if you find out that you have a barrier, contact your health plan. Every health plan has a process for you to get a hold of them, and you can ask them questions. Talk to your doctor, talk to the doctor's office. Make sure that you get the medication you need. And thank you for your time and attention today. It's been my pleasure to speak with you.
Thank you, Dr. Warnock. That was a tremendously helpful and insightful presentation. Our next speaker is well known across the kidney community, Dr. Alan Nissenson. Dr. Nissenson is a co-founder of Renal Care Innovation Holdings and a former chief medical officer of DaVita. He is an emeritus professor at the David Geffen School of Medicine at UCLA. Dr. Nissenson has served in many leadership capabilities within the kidney community over the past years. He has collaborated alongside past AAKP presidents Richard Knight and Paul Conway on multiple CMS technical evaluation panels to shape substantive patient-reported outcome measures under the CMS 5-star dialysis quality rating program. Most importantly, Dr. Nissenson shares AAKP's commitment to timely payment for and patient access to new innovations in kidney therapies that are becoming available during the decade of the kidney. Dr. Nissenson, it's a pleasure to welcome you to our summit. I turn it over to you.
Hi, I'm Dr. Alan Nissenson. It's a real pleasure to be able to be here today to present to the AAKP Public Policy Summit. So thanks very much again for the invitation. I'm going to spend some time talking about the barriers to innovation in kidney care and how we can overcome these and really move the needle forward. Just so you know, some of my potential conflicts here, I'm a partner and co-founder of a company called Renal Care Innovation Holdings, which works with new and innovative companies trying to bring products and new innovative care models to the marketplace for kidney patients. I'm also on the board of directors of several companies in the kidney care world, including Angion Biomedica, Rockwell Medical, and Diality Incorporated. We all know that the issue right now with improving the care of patients with kidney diseases is that we need to have more innovation and we need to make sure there's access to care. In the US, we spend a tremendous amount of money to treat patients with chronic kidney disease who are on dialysis, over $30 billion, nearly 7% of the overall Medicare budget, but only about 1% of patients in Medicare actually have chronic kidney disease and are on dialysis. In addition, there are nearly 40 million people in the United States who have CKD but aren't yet on dialysis. So what we really need to focus on are how do we identify kidney diseases early? How do we slow the progression of chronic kidney disease? How do we broaden patient access to kidney care choice that's consistent with individual patients' life goals? And how do we bring truly innovative products to market with appropriate reimbursement and payments? It's ironic that we are having a discussion in 2022 about innovation and the lack of innovation in kidney care. If you look back 10 years to 2012, In that year, the Kidney Health Initiative was launched, which is a very creative and forward-thinking effort to bring together public and private organizations to work on accelerating innovation in kidney care. Again, 10 years ago, very forward thinking, nothing like it in any other medical specialty. Yet here we are 10 years later, lamenting the fact that we still haven't seen the kind of innovation in kidney care that patients deserve. And in fact, even more recently, programs like the KidneyX Innovation Accelerator, the project started by ASN and the Department of Health and Human Services to fund new research into kidney diseases. The AAKP itself in 2019 launched the Decade of the Kidney. The executive order issued by President Trump advancing American kidney health, again, happened in 2019. And the Kidney Care Partners Kidney Care First framework, which emphasized innovation, was also issued in 2019. Yet here we are, still not seeing the kind of innovation we would like to see. It's important to understand the context of innovation in kidney care and the scope before we get into the specific barriers to innovation and some of the potential solutions. So when we talk about innovation in kidney care, we really are looking at three separate areas. One is pharmaceutical discovery and delivery. Second, development of new and innovative medical devices that can be used by kidney patients. And third, design and implementation of transformative care delivery models. So what is the real contextual framework that we need to consider and that we need to make sure that potential scientists, engineers, innovators, and funders think about when they're considering working in the kidney care space? And this really represents the journey that patients with kidney diseases go through over the life cycle of their illness. One is early identification of kidney disease. Secondly, interventions to slow the progression of CKD. Third, addressing the complications of CKD, such as anemia or metabolic bone disease. Fourth, proactively planning and ensuring optimal choice of treatment plans. And that includes transplantation, hopefully preemptive transplantation, but if not, living donor or deceased donor transplantation, and various forms of home dialysis, as well as conservative therapy for those patients who choose not to get a transplant or to go on to dialysis. There needs to be improved in-center dialysis equipment and treatment paradigms for those patients who choose in-center dialysis. And at every stage, patient involvement and patient insights are critical. What are the barriers to successful innovation, and why aren't we seeing more innovation? First, it's important to remember that many of these barriers are common to the entire scope of innovation. That means pharmaceuticals, devices, as well as care delivery models. On the other hand, some are specific to pharmaceuticals and devices because in those two cases, regulatory approval is required, generally from the FDA. In the case of care delivery models, patients, physicians, and payers need to accept the new care delivery models if they're going to be successful. So what's the real elephant in the room here that's holding back innovation in this field? And remember that for innovation to take place, it requires dedicated, motivated scientists and engineers, as well as willing funders or investors to make sure that innovation truly happens. But what's holding that back? First, we have a very perverse bundled payment system, particularly related to the payment for end-stage kidney disease patients. And I'll say more about that in a minute. There's a lack of mechanisms to pay for new drugs and devices that improve patient lives. And this really relates to the bundled payment system. And that is, it's not clear that if a new drug or device is developed and is made available, that there will be any payment for that. So that is a huge disincentive for investors as well as scientists. Third, there's a very paternalistic view by the FDA and the need to protect the vulnerable patient with kidney disease. I'm going to say more about that in just a minute. And what it really represents is that for our population of patients, the FDA, whose charge is really to balance benefits and risks of a new drug or a new device, the FDA tends to weigh very heavily on risk and give much less credence or value to benefit, particularly if the benefit relates to patient factors such as quality of life, patient convenience, and patient choice. And finally, there's a lack of coordination between the FDA and the major payer, at least in the case of end-stage kidney disease, which again creates uncertainty about approval and payment, which discourages investment in this area. So why haven't we seen more innovation? A few of these points I've already made on the previous slide, but I do want to emphasize a couple of others. One, when scientists or investors think about the kidney care space, there's often a lack of insight about how complex this environment is. And I mean that patients, caregivers, including nephrologists, companies that provide dialysis services or other care delivery models, as well as payers, are all part of this group of disparate stakeholders. And often people who want to get into this area don't really understand this very clearly. In addition, there's very poor understanding of the key strategics in kidney care. And in this country, in the United States, the key strategics are DaVita, Fresenius, and Baxter primarily, and the concern of potential scientists or investors that if these large organizations, the strategics, don't approve of or don't accept whatever I'm working on, that I will be doomed to failure. So tremendous risk there. There's also very limited involvement of patients in product development, and I'll come back to that a little bit later. And the other items which I've already emphasized on the other slide relating to the current payment environment and the way that can disincentivize investors and scientists to innovate. So let's talk a little bit about the FDA, because at the end of the day, even if you overcome the initial barriers and you get scientists interested, you get investors interested, they work on a new project, a new drug, a new device. At the end of the day, the FDA has to approve the drug or device in order for it to move forward and ultimately get to patients. And I want to give you some examples of recent rejection of kidney drugs by the FDA. Tenapanor is a drug which can significantly lower serum phosphorus. It's completely different from the traditional phosphate binders, and it is already an approved drug for other indications. This drug has now been rejected by the FDA, not because it doesn't lower phosphorus, which it does, but because the FDA has decided to move the goalposts and to say lowering phosphorus isn't enough. The manufacturers of tenapanor need to demonstrate that if the phosphorus goes down, there is some demonstrable clinical benefit. And that is a goalpost movement that has never been required of another phosphate binder. The good news is there is another advisory committee meeting coming up on November 16th, which will discuss this drug again, and hopefully it'll get approved. A second drug is Vivaramir, which is a drug to treat metabolic acidosis in chronic kidney disease patients. Very common condition and has been shown to be associated with accelerated progression of chronic kidney disease and mortality. Again, clinical trials showed that when you give the drug, the serum bicarbonate does go up as expected, no side effects, but the FDA still wouldn't approve it because a hard outcome, namely change in progression of CKD, was not statistically significant. And at the bottom, I've listed 3 of the new anemia treatment drugs. These are called HIF PHIs. It's a new category of drug to treat anemia, different from Epogen, which is commonly used. And there's a 4th drug called daprodustat, which also was recently evaluated by the FDA. All 3 of the drugs listed here have been rejected by the FDA. The 4th, which was the most recently evaluated, has been a recommendation by the review committee, was 13-3 in favor of approving for dialysis patients, but 5-11 against approving for CKD patients not on dialysis. And the irony here is that the main benefit of these drugs is that they're given orally. So their major benefit is for home dialysis patients, but also for CKD patients not on dialysis. And again, they were rejected. And I say these are examples of the paternalistic attitude of the FDA toward kidney patients. And I want to illustrate that by showing you, the other day I was watching TV and I just wrote down some of the drugs that were being advertised over a couple of hours when I was watching, and I've listed them here. And again, all of these are FDA approved. All of these are for non-life-threatening, although unpleasant medical conditions. And all of these, if you look at their package insert, have very similar side effects to all of the drugs that I showed you on the previous slide that have been rejected by the FDA for kidney patients, such as allergic reactions, anaphylaxis, worsening heart failure, vascular clotting, GI bleeding, and mortality. So for some reason, our drugs seem to be scrutinized to a much greater extent than many other drugs that are evaluated by the FDA. So what's the typical approach when an entrepreneur, the scientist, or a funder wants to develop a new drug or device? First, they identify a gap in care. They identify a product that could fill that gap, that create a pitch so that they can get more investors. Then they modify what they're doing to fit the potential investors and make sure they can get money. They try to raise financing through capital markets. They work through clinical trials very aggressively to get FDA approval, and then hope one of the strategic partners will acquire the company and see that it's commercialized. And why doesn't this work? Well, unfortunately, the people who are going through this process generally have inexperience in the execution of clinical and business plans. So there needs to be a focus on patients and patient needs rather than the needs of the investors or the demands of regulators. There's an underestimation of the funding required really to get through all of the processes that will lead to availability of a product for patients. And there often is a lack of experience, executive leadership in these companies that are trying to develop innovations. And the result is the approach I outlined often doesn't work. So patients are generally not involved. There's a fundamental gap in insights about the complexity of kidney care. There's a lack of understanding of the needs of stakeholders. There's a challenge which often can't be overcome of engaging dialysis organizations. There's poor understanding of other key strategics in the area, and then challenges because of the payment system to full commercialization. So what can we do to drive innovation? So the story isn't all bleak. There are things that can be done. Once we understand the barriers and the challenges, then there are things that can be done. First, engage the general public as well as patients with kidney disease in their insights in all aspects of innovation. So get some additional public relations around the burden of kidney diseases and the potential for innovative products and delivery approaches to improve the lives of patients. Secondly, articulate the narrative of the clinical journey of patients with kidney disease. And that way we can better understand the current gaps in kidney care innovation. Third, try to identify innovations that will make a difference in the next 2 to 4 years. So look at the time horizon. There often is a tendency to look at long-term solutions, at grandiose innovations that might take 10, 15, 20 years to be achieved. But we need to look at what are things that can be done in a short time frame that can be applied to improving patients' lives. And finally, educate key health science investors in opportunities to improve kidney care, and that will also produce a fair return on their investment. And I just want to emphasize that involving patients right from the beginning of conceiving of an innovative idea and through to the end, which is development of a product, is critical. On the right-hand side of this slide, you can see what patients say are things that really are difficult for them and that they focus on, patients with kidney diseases. But on the left-hand side, and this list was provided to me by Paul Conway, we've listed the really high-level things that are important to patients and that should be considered when any innovation is being developed. What are the medical health implications? So how will my primary condition or comorbidities or other conditions be impacted by this innovation? What will the impact be on my family or caregiver? Will this add to or relieve stress on my family, on my children, on quality of life for them as well as for me? How will it impact my employment or my ability to be employed and to make a reasonable income and maintain mobility in the workforce? And finally, how will this innovation align with my aspirations? Will it align with my life goals, things such as travel? Finally, a couple of words about the FDA, since I spent some time talking about the challenges and the disappointments we've had working with the FDA, but there is a way forward, not only by working through the Kidney Health Initiative, which includes representatives of the FDA, but also by working with the agency to emphasize benefit of innovations, by working with them to create formal patient preference studies so that patient preferences are a key part of the evaluation process, by looking at how disease burden is addressed by the new innovation, by looking at patient experience data, by having patient-focused drug development meetings with the agency, and to use real-world evidence to support applications, meaning talking with current patients. In terms of study design, and this is a burden on us as investigators or as developers, we need to incorporate patient-reported outcomes into our clinical trials. We need to have frank discussions about whether hard outcomes always matter or whether intermediate outcomes, for example, lowering of serum phosphorus or improvement of quality of life, should be enough. And this is my final slide. What else can we do to drive innovation in kidney care? We need to talk to the external world, including potential funders, and articulate the rewards of investing in kidney care, along with some of the intangibles. So it's not just financial awards, but also name recognition to try and get angel investors to be early investors in new ideas. We need to have better collaboration of key advocacy organizations, AAKP, ASN, RPA, and others, to create legislation that better authorizes reimbursement for new devices and pharmaceuticals outside of the dialysis bundle. There are transitional payments for drugs and devices now, but they're very short term and really don't help to a great extent to encourage investors to invest. We need to widen efforts to work with other key federal agencies to leverage their experience in driving innovation, and then hammer home the message that new care models, not just drugs and pharmaceuticals, that are created on the basis of patient care choice, value-based care, and fair reimbursement are also innovations and are just as important as drugs and devices. Thanks very much for your attention to this presentation. It's been a pleasure being a part of the AAKP Public Policy Summit, and I hope to see much more innovation in the future to greatly improve the lives of patients with kidney diseases. Thanks very much.
Thank you, Dr. Nissenson. For someone immersed in the kidney space for decades, your insights and expertise on aligning payment and regulation to support innovation is invaluable. And finally, moving to our last speaker is Dr. Mahesh Krishnan, Group Vice President of Research and Development at DaVita. Dr. Krishnan has worked closely with AAKP over the years through our joint involvement in major collaboratives, including the Kidney Health Initiative, where he served on the KHI board with AAKP's past president, Paul Conway. He has also worked closely with past President Richard Knight to address disparate access to kidney transplantation, especially among underserved communities. Dr. Krishnan, it's a pleasure to have you with us for the Policy Summit, and I turn it over to you.
Hello, my name is Dr. Mahesh Krishnan. I'm a nephrologist, one of the DaVita Chief Medical Officers, and the Group Vice President for Research and Development. I'm really pleased today to be able to speak to you at the AAKP around innovation in kidney disease, talking a little bit about the overview there and the barriers to allowing innovative technologies to come to patients with renal disease. There's a lot going on in kidney diseases, and I'm going to talk to you about a number of these different things, but you've probably heard of a number of these items. The first is in chronic kidney disease. We use medications such as SGLT2 inhibitors, which were originally approved for diabetes, but now demonstrate great promise in terms of slowing down the progression of renal disease, as well as improving with congestive heart failure outcomes. There's an innovative new company out there called ProKidney, which is looking to create a cellular therapeutic that also can help slow down the progression of chronic kidney disease. In the ESRD side, we have some new drugs. There are hypoxic-inducing factors, which are essentially an oral version of the ESAs that we've used before to treat anemia. And there is Korsuva, which is a new medication for urine pruritus or itching. There are also new devices. For instance, there's a new dialyzer that's out that might have some benefit. There are new machines in the home and elsewhere. There are new machines on the in-center side with new technologies that improve safety and efficacy for patients that dialyze on the in-center side. And there are advances in peritoneal dialysis technology with regards to monitoring of peritonitis and other complications, which might even improve the time people can be on therapy, as well as improve the overall effectiveness of the therapy. And in transplant, there's some exciting new developments. There are new diagnostics that are out there to basically detect rejection, potentially avoiding the need for a biopsy. There are xenotransplant kidneys, which are basically kidneys that come from pigs that can actually be implanted into humans and address the shortage of organs. And there are also bioengineered organs that are developed by companies such as Miromatrix, where you can take a pig kidney, decellularize it, put in human cells, and it can be almost as effective, potentially, as a human kidney. All of these things demonstrate great promise and innovation in kidney disease. But what are the 4 hurdles to actually translating these scientific endeavors into a clinic near you? These 4 hurdles actually come from pharma, but are applicable to any technology that needs to be moved from theoretical to translational, from bench to bedside, if you will. The first hurdle is it safe and is it effective? The second hurdle is, can it be manufactured consistently? The third is there awareness and can it be accessed easily? And the last is, and perhaps most important for this conversation today, given the topic you guys have already covered, is will someone pay for it? I'm going to go over each one of these hurdles as it relates to kidney disease and describe to you what they are and how they potentially could be overcome, with a specific emphasis around how you as patients can actually be involved and be an active participant in making some of these things happen. Hurdle 1, is it safe? This is paramount. Obviously, the FDA, the Food and Drug Administration in the US, does a lot of review and also mandates clinical trials. And this is their way of understanding whether a drug or a therapy or a diagnostic is safe and effective. There are barriers that actually exist, and you might have already spoken about these earlier. These include trial recruitment. How easy is it to recruit the number of patients that are required? Is it representative? Are the populations that are being studied the actual populations that will receive the drugs? And then there's actual trial conduct. How well can the trial be done? And then the analysis of the data. It is critically important to have some clarity on trial design and endpoints. There's a current debate that is going on around the low success rate around recent renal drug approvals, and to need to understand whether or not statistical separation is even possible, or if new endpoints are needed, similar to oncology. Now, what does that mean? It might mean that some of the endpoints that traditionally work for other disease states, perhaps not in end-stage renal disease, don't actually work in end-stage renal disease. And that if you're looking to see whether or not one arm performs better than another arm, it might be the case that you have to look at other outcomes other than traditional things such as mortality or morbidity. But there's a lot of debate going on as we look at the new drugs that are coming to market and how the FDA evaluates those with their trial sponsors. For you as patients, I think it is very important to be an active consumer and discuss safety issues encountered through the appropriate reporting mechanisms. If you see an issue, it's best to always come back and talk about it to make sure that people are aware. The FDA has surveillance systems that are in place to do this, which we'll cover later on. The second hurdle is, can it be manufactured appropriately? Again, the FDA, when they approve a product, doesn't just focus in on the safety and efficacy, the clinical trials we just talked about. They also focus in on manufacturing. If it's a pharmaceutical, is the plant safe? If it's a medical device, is the plant effective? Is there a surveillance system to understand what happens? The FDA also employs a post-marketing surveillance program. One of them is called MedWatch. And this is an actual active, what we call active reporting system, meaning if there are issues with drugs or other devices, that there's an active way to let the FDA know. There's also experimentation with passive reporting systems where you can use electronic medical record systems and other systems in order to identify whether there's issues with drugs or devices or other things that the FDA regulates. Again, I think that patients can and should be involved in this process, and there are many ways to actually do this. The FDA actually has patient interaction opportunities, which you might have spoken about earlier, and the Kidney Health Initiative, a joint partnership between the American Society of Nephrology and the FDA, also has a patient advisory council where you can get involved and talk about trials, trial design, interactions with how drugs and devices interact with patients, all critically important in order to identify whether or not things are being manufactured and delivered appropriately. Hurdle 3, is there awareness? And can it be easily accessed? Now, this is important. This is how do patients and providers and physicians, how does all this get educated? And this knowledge dissemination is really, really important. Conferences such as the ones we're attending right now with the AAKP, conferences such as the Kidney Health Initiative, the American Society of Nephrology, the Annual Dialysis Conference, and the Ideas Conference are all areas where you can get a really good understanding of either what's coming in the future or what is already out there. And that's really important because if you don't know about a product, it's really hard to know that you want it or don't want it. It is also important to address some of the issues of SDOH, or social determinants of health. These are non-traditional risk factors which might affect people's ability to access a therapy or utilize something. So for instance, if you're a patient that has an issue with housing insecurity and extreme homelessness, it might be difficult to access a home modality. But as we talk about it, as we think about it, there's adaptations that can be made. The same is true for aspects of financial issues or aspects of health literacy. And so this access and awareness is a topic that is broad reaching. It covers many different stakeholders, and it also has the potential to be customized to the various subsegments of patients and physicians in order to overcome some of these issues, such as social determinants of health. I think the call to action there is patients can and should be a more educated consumer. It is important to know what is possible, and so you can advocate for it and ask your providers or your physicians for these new and innovative therapies, because if you don't know about them, it's really hard to go and see if they're appropriate for you. Hurdle 4, which we're going to spend a lot of time on, is will someone pay for it? And I think this one is quite important. And I'm going to cover CKD and transplant first because those are actually less complicated, quite candidly. And then I'm going to spend some time on the specifics of how innovation comes into the end-stage renal disease payment system for dialysis, and what some of the actual acronyms are, and what some of the pros and cons are of each one of those. So for CKD, or chronic kidney disease, renal patients not yet on dialysis or not with a transplant, many of those are actually done through physician codes. So CPT codes are procedural codes that physicians can use to access new technologies, such as new labs or new devices. And then if you have Medicare Part B or Part D, there's another way that you can access new and innovative therapies for chronic kidney disease. So Medicare Part B, these are the injectable medications that you might get in an infusion center, and Medicare Part D or oral medications. I will add here that some patients may actually also be on Medicare Advantage. And these same codes generally apply, but there's a second layer of oversight with the providers that administer those Medicare Advantage plans. And so when something is covered in Medicare B or Part D doesn't necessarily mean it's immediately covered on Medicare Advantage. And so that's a different process that a patient might need to navigate in order to get a new drug or a new device or a new pharmaceutical. Transplant is a little bit more less complicated. Transplant uses what's called a retrospective payment system, where transplant centers figure out how much it costs them to do a given thing, whether that's the initial workup or whether that's the transplant surgery itself for some period of time after the transplant. And then based on their costs, they get some reimbursement based on that. And so I would actually say that the ability to get new and innovative therapies into transplant is actually easiest of all the three categories we're going to talk about: CKD, transplant, and end-stage renal disease, for that very reason. And I think as patients, the support for innovation, coverage, and reimbursement policy is critically important. Coverage meaning, will this be something that a payer will pay for? And reimbursement essentially meaning, how much will they pay for it? And I have here the logo for CMS, which is the largest payer, and we'll talk about them pretty commonly, because as the largest payer for end-stage renal disease, they pretty much set the precedent for what is paid for in dialysis, and private payers and other plans generally follow their lead. So let's talk about end-stage renal disease specifically. The first program I want to talk about is something called TDAPA. TDAPA stands for the Transitional Drug Add-on Payment Adjuster. What is that? Why does it even matter? When the original end-stage renal disease bundle was created in 2009, a certain amount of services were included in that. So what it took to do the dialysis session, a certain number of new medications that were present in 2009, a certain number of labs, and a certain number of devices. Well, clearly the world has evolved, right? If we were thinking about what we were walking around with in 2009, we'd all be walking around maybe with Palm Pilots, and we wouldn't even have heard of cell phones, right? It would have been a completely different time, but technology has evolved. And so TDAPA is a mechanism that allows new drugs to come into the bundled reimbursement system, and CMS will then pay for it for a certain amount of time. So essentially the way it works, it's a very transparent process actually with CMS. If a new drug is approved by the FDA and is one of very specific types of new drugs, then it can qualify for TDAPA. And so the manufacturer would get the drug approved by the FDA, would go to CMS and get a reimbursement code, and then armed with these two things would go to a very specific office at CMS and say, we'd like to qualify for TDAPA. And if those two criteria are met, the FDA approval with a specific type and the payment code, then TDAPA is generally granted. And what TDAPA means is that there is a 2-year period for which this new drug is paid for outside of the bundle. And CMS has done this to encourage providers to be able to access new drugs and determine whether or not they're useful or not useful. And at the end of this 2-year period, in most cases, that money is withdrawn, and then you're back to whatever the base rate was for payment. Now, in certain cases, this is not really sustainable. And as I talk about the evolution of this policy, this post-TDAPA policy is really required for sustainable innovation. So if we take an example that is relevant today, and we look at the drug Korsuva, Korsuva is a medication that may hold great benefit for patients with uricaritis or itching due to kidney disease for some patients. However, the amount of money that was originally put in the bundle in 2009 only really covered oral Benadryl, so a very small amount of money that was in there. And so if we were to use this new medication that actually is expensive, or at least costs more than Benadryl, and there was no incremental reimbursement after the TDAPA period, that would be a big problem. And so there is a conversation going on. CMS actually had a request for information over the summer to say, well, what should we do with post-TDAPA? Is there certain drugs that should get more money back in the bundle? Because obviously oral Benadryl isn't going to cover the cost of Korsuva. And then how should we think about that? So that's the debate that's currently going on. The second issue that I want to just cover briefly also goes back to Medicare Advantage. And this is this important aspect of coverage parity with Medicare Advantage and with traditional Medicare fee-for-service. So traditional Medicare fee-for-service is referred to as Medicare Part B, and Medicare Advantage is referred to as Medicare Part C. And right now there is no equal mandate for someone who is in Medicare Advantage to have the same innovative drugs covered in TDAPA. And so that's a conversation that's currently going on. How do we ensure that if a Medicare Part B patient has access to a new drug through TDAPA, that also translates through to the providers that are administering the plans for Medicare Part C, and so that the dialysis unit in this case can not have to worry about insurance coverage between fee-for-service and Medicare Advantage. The second aspect of innovation in end-stage renal disease that I'd like to cover is actually is what's called TPONIs. And TPONIs is a version of getting new devices into the ESRD bundle payment system. So I spoke to you about new drugs, the new devices category, because in dialysis we use a lot of devices, whether it's home hemodialysis equipment or in-center hemodialysis equipment, remote monitoring or home technology. It's a lot of devices involved. And so this is a system that is similar but different than TDAPA. So one, the product has to be approved by the FDA. That's generally the case. But CMS and then the manufacturer can apply for this TPONIs coverage. But the manufacturer has to essentially prove that the product that's being used, the device that's being used, is substantially better than something else. It must demonstrate what's called SCI, substantial clinical improvement. And today, that process with CMS is not as clear as I think the TDAPA policy is. So they operationalize what's called coverage with evidence determination, which is they'll allow a 2-year period for new technologies to be covered, but the approval of that, whether or not it's guaranteed this new money or not this new money, is not clear. So the endpoints are not really well clarified beforehand, versus the TDAPA policy, it's basically if the FDA approves it, they'll cover it. In this case, it's a subjective decision by CMS based on the evidence that's supported and given to them as to whether or not they will cover this or not. And so one evolution of this process could be to increase the transparency of this process, to essentially advocate for what I'll call peri-FDA submission review with CMS to clarify what is required. Now, let me just break that down for you. Essentially, what we're saying is, at the same time the manufacturer of a device goes to the FDA and says, look, I want to get this device approved. Can you tell me what I have to do that? They could go to CMS at the same time and say, look, I'm trying to get this device approved. Here's what my clinical trial will show. If I show these things, will you give me payment under TPONIs? That parallel review, I think, will be quite important. It would give the manufacturers confidence that they should come into the renal space. It'll reduce the uncertainty for a lot of different things, and I think it could be a meaningful improvement. There are examples of this parallel review where CMS and FDA are reviewing things in parallel rather than in sequence in other areas of healthcare, and so that could be quite interesting. And again, here, the same issue that we talked about before on TDAPA with Medicare Advantage should be highlighted, which is that we would like to see innovation parity between Medicare Part B, which is regular fee-for-service, and Medicare Part C, which is Medicare Advantage. And so that if TPONIs is granted in Medicare fee-for-service, that we also get that same coverage benefit with reasonable reimbursement on Medicare Part C, Medicare Advantage, such that, again, at the dialysis clinic level, we don't have to decide between who has access and who doesn't, because they're all covered by Medicare. Again, the call to action here for patients is, I think, exactly the same, which is to support both innovation coverage and reimbursement policy. I'd like to cover 2 more topics with you, and this is something that the community introduced and talked about just over this last summer. And this is what I'll call TLAPA. And yes, it sounds like a fish, but what I would say this is the Transitional Lab Add-on Payment Adjuster. So you might recall that the reason for TDAPA and the reason for TPONIs was that when we created the bundle payment system in 2009, we kind of froze time and said that's all that's going to happen. Well, there's a lot of diagnostics that are required in kidney disease, right? A lot of kidney disease is measured and monitored by laboratory tests. And so we think that there is great potential for new innovation to come into the bundle related to laboratory diagnostic testing. And there are some good examples from outside the US. There's tests that measure vascular access calcification. There's tests that measure residual renal function that are used in countries outside of the US that have no clear mechanism for reimbursement within the United States. And so we suggested this year as a community that there is no clear path for new laboratory innovations, and we could potentially think about something that would allow new labs and diagnostics to come into the end-stage renal disease bundle, just as we've talked about drugs and devices. It could follow either one of those processes. The TDAPA process, which is just FDA approval. It could follow the TPONIS process, which is FDA approval plus a subjective assessment by CMS around substantial clinical improvement. I think we might all think that the TDAPA policy might be the right answer of thinking about it. And again, similar to those two policies, we might need to think not just about a small period of time in which this is covered, but how we continue to add money back into the bundle to make sure that patients have access to these innovative therapies even after an initial 2-year period. And then just to be a little provocative and future reaching, I think there are some new things that are coming down the pike that really could benefit from some thinking around coverage and reimbursement policy. So wearables, for example, there are some great companies that are thinking about peritoneal dialysis wearables or hemodialysis wearables where the dialysis is done almost constantly. You wear a belt or a device and your dialysis is done as you walk around, which would be a great convenience and a great benefit for many patients. How should those be paid for? Some argue those should be paid for as a home modality, no different than ambulatory peritoneal dialysis. Some argue they might need to be put into a completely different payment system. I think time will tell, but it's important, I think, to start having these conversations and debates as you see these new technologies coming into fruition. Next, we can talk about implantable artificial kidneys. There are some people that are working on mechanical devices to replace kidney function, which would be amazing for patients. No external device, no going to dialysis, just an implanted device that purifies the blood and puts the urine back into the bladder. That would be amazing. Which payment system does that fit into? Is that an end-stage renal disease payment system? Is that a surgical code? So that's an idea just to think about. And then I know you've probably already covered xenotransplantation already, but this idea of solving the organ shortage by increasing the number of organs that could be available from pigs and others. Again, how do we think about how that gets paid for? Is that a different process than how transplant gets paid for today? Do we use the same process? Instead of saying it's a human organ, it's now an artificial organ. So I recognize these are somewhat far-reaching ideas, but I do think that these technologies are on the foreseeable horizon. And so it is important to continue to think about how they could come in. But again, the call to action for you all as patients and patient advocates is really to support this new innovation coverage and reimbursement policy for these new things. We want to ensure that patients with renal disease have access to new and innovative therapies, and that all starts not just with the science, but also the coverage and the reimbursement. So where are we today, if I were to summarize where we are? So there's lots and lots of innovation. I hope I've shown you today that innovation is alive and well, and that as patients with renal disease, you should be not pleased because we haven't cured renal disease yet, but you should at least be optimistic that there's lots of people trying to innovate in renal disease. And we've covered the big areas. We've covered chronic kidney disease. We've covered transplant. We've covered end-stage renal disease. There's also a lot of service innovation that's happened. One of the side effects of the pandemic was a lot of more telemedicine applications, remote patient monitoring. So I think there's tons of new things that are coming. But the key thing I want to emphasize to you, if you take one thing home with you, is it is insufficient to just have the science or the technology or the product. You also have to figure out how to do the implementation science, we'll call that, right? How do you get this from theoretical bench to bedside? How do you make sure that we translate all this technology into something that actually positively improves the lives of patients with renal disease and the providers who've dedicated their lives to take care of them? In a great analogy, I'd say, look, a lot of these technologies are cars, or engines. And most of us are not in the market to go buy an engine. We want a full car, right? We want everything that surrounds that engine to do what we need it to do, which is to go from point A to point B. And so the implementation science is really taking all of that great technology in the engine, putting all the pieces around it, and making it a car that actually delivers value. And to do that, as I've mentioned to you today, there are these 4 hurdles that we've talked about. Is it safe and effective? Can it be manufactured appropriately? Is there awareness for people to know how to get it? And most importantly, will someone pay for it? And these 4 hurdles, just like in field and track, need to be overcome in order to get to the end and get to the finish line. So again, the future of innovation to improve the lives of patients with renal disease is bright. I'm really excited about all the different new technologies that are coming, but we do need to continue to improve the access to these innovations with some of the things that I've talked about. And what I would encourage you as patients and patient advocates is to continue to push the envelope, to continue to push providers, to continue to push payers, to continue to push innovators to ensure that you have adequate cars that improve the lives of everything that you do on a daily basis, and thus actually really make a difference for the renal community. Thank you.
Thank you, Dr. Krishnan, and thank you to all of our speakers. We appreciate you sharing your time and expertise with us and your perspectives on issues that are impacting kidney care.